Welcome to the Psychiatry recall session of NEET PG 2025. First of all, I sincerely hope each and every one of you had performed well. And from my bottom of my heart, I truly pray that all the six questions in psychiatry were a walkthrough for you and that you have nailed each and every single question which are appeared in the NEET PG 2025. This session is not to make you guys feel bad or revisit what went wrong, but rather it is about reflecting and learning. Even if there are areas where mistakes happened, don't worry. This is the chance for you to understand, correct, and strengthen for the future. Whether it is the next phase of exam, counseling, or any other further academic path you take. Psychiatry has always been one of the high yield subjects that students often tend to underestimate. But we have been consistently over years say that if you prepare right, all the questions are guaranteed for scoring in psychiatry. Let's walk through each and every question, decode the concept, identify the traps, and learn how to approach them smarter. Whether you are continuing with the counseling or preparing for the next cycle, this session is meant to help you grow stronger in the subject. So let's begin with. So if you see the pattern this time, so they have asked one question from basics, one question from schizophrenia, as I always tell, one question was from the trauma and stress related disorders, one from personality disorders, one from dissociative disorders, and one from forensic psychiatry. One thing which I got surprised is there was no questions from alcohol. First time in the history of NEET PG, alcohol was not asked. Even a single substance itself is not asked. So they are moved away from the substance. I think this is the first time I'm seeing. But anyway, they have touched some important topics. Usually they go with mood disorders, but rather this time they went into stress related disorders, which often students gives less preference while reading because we often go with the schizophrenia, mood disorders, child psychiatry. We concentrate in those areas, but this time unfortunately they have covered trauma and stress related disorders, personality disorders, and your dissociative disorders, which are most common. But nevertheless, if you had already seen our GMI session or the dopamine surge session, you would have known that I had covered all these topics with equal importance. And if you had attended those sessions, I'm sure that you had answered these questions also correctly. Next, let's move into the first question of discussion today. Mr. K was brought to psychiatrist by his friend, complaining that Mr. K needs everything to be perfect in order and has difficulty in getting rid of things stored with him, both of which are affecting his quality of work. Perfectionist. However, Mr. K denies such complaints. Like Mr. K is not denying of any such complaints. He is telling that his personality is like this. So here it's a personality disorder. So when I talk about the personality, what does it tells? Everything to be perfect. When something like this word comes, we call this as anancastic traits. Anancastic traits. So what does this anancasticity means? Anancasticity means that they want everything to be perfect. If they are scoring even less, 1 mark lesser than the centum, they will be like feeling worried. If something is not kept in that place where they are kept in a symmetrical manner, if it is not there, then it is also a personality of anancastic traits. So it is not OCD. It is not obsessive compulsive disorder, but it is a obsessive compulsive personality disorder. It is a normal thing when you call it as a disorder. You call it as a disorder when it starts to affect your functioning. So here the question clearly tells both of which are affecting his work quality. Okay, difficulty in getting rid of things stored with him, and both of them are going to affect his quality of work. That means there is an occupational dysfunction because of this quality in his personality. That is why we coined the term it as obsessive compulsive personality disorder. If I coin the term traits, that means the person is having functionally okay, but even then the patient is having some sort of perfectionism in his life. So the same question next year, it can be twisted further. They can ask you that the patient is having All this problem, working in perfect manner, wanted to be everything in symmetry, gets angry when things are changed from its position where the person had kept. So all this history they are giving, and they are going to change the slightest terminology that, but the patient is functioning well in his occupation. He is going for work regularly. If at all they ask you such a twisted question in next year exam, then the answer is obsessive compulsive personality traits. It is not obsessive compulsive personality disorder. They can give both in the option and they can ask you. So your answer should be obsessive compulsive personality disorder. So I think I have covered this in my session also. Actually, there are three clusters. We call it as cluster A, cluster B, and cluster C. So cluster A is a odd, weird, and eccentric, in which you have paranoid personality, schizoid personality, and schizotypal personality. In cluster B, you have antisocial, borderline, histrionic, and narcissistic. And your cluster C is a avoidant, dependent, and unencastic trait. Unencastic trait is otherwise called as obsessive compulsive trait. So what is the meaning of it? Rigid, perfectionist, preoccupied with control and order. So that's what I have given you in your notes also. When I took the class in the dopamine search, I have given this table and I asked you to remember just the keywords. If your question gives you perfectionist, then the answer is obvious. It is obsessive compulsive traits and obsessive compulsive disorder when the patient's functioning is affected. I hope so that every single person who had attended my classes should have written this question correct. So this is going to give you directly 4 marks for your NEET PG. Clear? Next, second question. A patient presented to the ER with recent loss of memory. First point is recent loss of memory. And she claims that she has lost her father just 2 weeks ago and frequent flashback about the same. I still remember that this question, when I was discussing in dopamine search, same question I had given in your exam, in your dopamine search session, except that instead of 2 weeks, I had given 1 month. In that session itself, I told you, if you get a question with this flashback, with this recent loss of memory, with similar situation, okay, your answer should be based on the timeline given for you. If it is less than 1 month, then it is acute stress disorder. Acute stress disorder. And if it is more than 1 month, okay, if it is more than 1 month, then your answer must be, when if it is more than 1 month, then your answer must be, what must be your answer, guys? Can you tell me? What must be your answer? Then your answer has to be, okay, acute stress disorder or PTSD. Then your answer has to be PTSD. Okay, is it clear, guys? Any doubts? Hope there is no doubt, isn't it? Okay, so let's move into the next question. Okay, so this question, I think I wanted to discuss. So this question, I also wanted to discuss that if you get less than 1 month, within 1 month, then your answer has to be acute stress disorder. And if it is more than 1 month, then your answer has to be post-traumatic stress disorder. So I can rule out these two options. But why not? Okay, why not? This is not the answer I have told you. But why not? It is a dissociation disorder. What is the difference between an acute stress disorder and dissociative disorder? Because dissociative disorder can occur anytime. It can occur in the less than 1 month also. Then what makes the difference between acute stress disorder and dissociative disorder? In acute stress disorder, guys, there will be a trauma present. Like we have given in this question that there is a loss of father in the RTA. Same way, even in dissociative disorder, you will have a traumatic incident. But the difference between a dissociative disorder and acute stress disorder is you will not have flashback, or it is not typical in dissociative disorder, whereas flashback occurs typically in acute stress disorder and PTSD. So our question more likely fits into this acute stress disorder. Is it clear, guys? I hope so you are clear with this question. Similarly, you have to also know what is a PTSD, which I have covered already in my previous session. PTSD means psychiatric disorder that can occur in an individual who have witnessed, or when there is any life stressor that had occurred. Let it be an accident, let it be a natural disaster, let it be a sexual violence, let it be a life-threatening situation. In all these time, what happens is your amygdala is going to become very active. Your amygdala is an emotional response to center, isn't it? So because of that, there is going to be a stress disorder. But this stress disorder, when it is going to be more than 1 month, then you call it as PTSD. So what are the symptoms you have in it? So I actually asked you to remember it as MAGI. M stands for mood. So there will be a negative emotion, there will be a negative belief, and there will be a low mood, and there will be avoidance of people and trauma related things, whatever it is. So if, for example, if the patient in this condition, they had a loss of father in RTA, so whenever she travels in the car, she started to have all those negative effects. So because of that, she will be avoiding to go to a car or travel by a car. And there will be hyperarousal. Hyperarousal means irritability, hypervigilance, decreased concentration. All this can occur. And there will be a intrusion symptoms. So there will be a flashbacks. There will be a distressing dreams. So this is exactly what PTSD is. So I have given a table for you to recall or just remember. Acute stress disorder, there will be a traumatic incident which will be present. So this occurs within 3 days to 1 month, and there will be a core diagnostic criteria as a flashback will be there, and dissociative symptom, yes, may be present, amnesia may be present, mood disturbances will often be there, the patient will be negatively affected, and awareness about the impairment will be there, and functional impairment, yes, of course it will be there, and then you call it as acute stress disorder. Whereas in dissociative disorder, mood disturbance need not be there, number one. Number two, there will be again a lack of awareness about the memory gap, and the patient will be like having a flashback will not be typical in dissociative disorder. Hope you understand this question. Next. This question, yeah. This is a repeat question, direct repeat question from FMG exam. Direct repeat question from your FMG July exam. That is why I always tell in my classes, isn't it? Don't just recall or don't just revise all your NEET PG topics. Revise your INICET, revise your FMG. Sometimes they mismatch. They just take question from there and keep it here. Same way, just FMG 2025 July they asked. I recorded the FMG recall video just 1 week before. Same question. Not even a single point changed in this question. A healthcare worker found a female roaming in street 110 kilometers from the resident with no memory of how she reached there or what happened before. Healthcare worker later finds out that there was an earthquake in the town. What is the diagnosis? So what is the answer you guys wrote, guy? Can you tell me? Is it a dissociative amnesia, dissociative fugue, dissociative identity disorder, or selective amnesia? What was your answer? Most of them should have written it correctly, if not also learned now at least. So many people will be confused between these two things. Some would have written dissociative amnesia, some would have written dissociative fugue, but the answer is dissociative fugue. So what is dissociative amnesia before going into dissociative fugue? Inability to recall the autobiographical information that usually a traumatic or stressful nature and that is not consistent with the ordinary forgetting. See, even people forget things, but in this, the autobiographical information like the identity of the person will be forgotten. This includes dissociative fugue. So dissociative fugue is one of the component. It is one of the component of dissociative amnesia. Okay, where the individual who is having this dissociative amnesia will travel or wander away, often with confusion about the identity or the past. Okay, often about the confusions will be there about the identity or the past. So this is the diagnostic criteria of dissociative amnesia. What is a dissociative amnesia? An inability to recall important autobiographical information. Inability to recall autobiographical information. So that is called as a that is actually called as the dissociative amnesia. Here what happens basically is the person's identity will be like the patient will be forgetting it, and the symptoms will be causing a significant distress. The patient will not know where they are from. So that is like they don't know. Okay. And the symptoms cause clinically significant distress, and the disturbance is not attributable to the physiological effects. It is not attributed to any physiological effects, and the disturbance is not better explained by the dissociative identity disorder or post-traumatic stress disorder or acute stress disorder. Nothing explains it. Okay. And along with the dissociative amnesia, if the patient is also telling you that there is a purposeless travel, okay, apparently purposeful travel according to them, but purposeless, the patient will be like wandering around. Okay, if that is the case with loss of autobiographical information, then you call it as a dissociative fugue. So answer here is dissociative fugue. Basically, your dissociative amnesia is of 4 types: localized amnesia, selective amnesia, generalized amnesia, and dissociative fugue. Here, dissociative fugue is a specifier. For example, a man found in the distant city, unable to recall name and travel and reason for travel, they don't know. Whereas in generalized amnesia, what happens? The patient does not know anything. Whereas in localized amnesia, person can't remember anything from the day of incident. Whereas selective amnesia, for example, a soldier is fighting in a war and his friend expired. So that friend, when he got expired, that part alone he will be like forgetting, and that is called as selective amnesia. Hope it is clear. Okay, so again, the table I have given, this is I have given in the FMG session, same table I have taken here also. So it's very important to see the recall. That's why sometimes you don't know, only 1 or 2 word will be changed. About that 1 or 2 word changes also we would have anticipated and told you. So it's better always to look the recall, understand the PYQs first before moving in depth into the other questions. Okay, next we are going to move into the next question. A 35-year-old assault his co-worker in the office. He was in the opinion that the co-worker is going to kill him. So there is some persecutory delusions which is present. And he heard voices in the ear. So there is a hallucination. And he was found to have disorganized speech. So there are 3 components are present. So you would have remembered. So there is something 3 important first rank symptoms: hallucination, delusion, and disorganized speech. All these 3 is there. So what is legally correct? Take him to a court and start trial. Get a psychiatric consultation before taking up for trial. Refer him to the clinic for anger management. No legal action has to be taken as he is mentally unstable. What is this rule called as? Anyone remember? What is this rule called as? I gave it in the high yield paper which I have shared just before the exam. I told you, no, this question is there is high chances to come. Yeah, so there is something called as McNaughton's rule. This McNaughton's rule refers that if a person is having some psychiatric disorders, if he is proved to have psychotic disorders, if the person is mentally unstable, then there can be no legal action can be taken in the patient. So that means whenever you see this question, immediately your mind goes to the McNaughton's rule. And once the McNaughton's rule is like when you get to know, then immediately what you will think? The answer is option D, you will be thinking. But then to prove that the patient or the person is a psychiatric patient, you need to have a referral to psychiatrist, right? So the answer here is option B. Okay, so psychiatric evaluation is needed for 2 things. One, fitness to stand a trial, and for the criminal responsibility at the time of offense. For both these things, you need to take a psychiatric consultation. What is the McNaughton's rule? IPC 84, when Indian Penal Code was there, IPC 84 tells that nothing is an offense which is done by a person who, at the time of doing it, by reason of unsoundness of mind, was incapable of knowing the nature of the act, or that he was doing what was either wrong or contrary to law. So what does it focuses on? It focuses on mental state at the time of offense. So at the time of offense, if the patient is having some mental illness, and if the patient is not having the understanding about the crime he is going to do, then he is exempted from the trial. That's what IPC 84 tells. But who is going to authorize that? The patient is not having a soundful mind. It is psychiatrist. So you need to first take him to psychiatrist in order to certify him as mentally unstable. Once he is certified as mentally unstable, then you can tell that the patient should not be punished because of McNaughton's rule. So this is another thing. Hopefully they have not asked this question and all. So this IPC 84 is now replaced with section 367 of BNS. Same thing, but what they tell is they recognize the insanity defense again. The burden of proof but lies to the accused to show lack of criminal responsibility due to mental illness. So again, what they are emphasizing is it is accused who need to prove that, or accused lawyer who need to prove that the patient is actually no mentally unwell, so he cannot be trialed. So that has to be emphasized by the accused. Okay, so this can be asked in the next time. So take him to the court and start trial. It can be there because it's a premature. You need to get fitness to stand trial, and no legal action can be taken illa because law does not assume insanity. It takes into consideration after a psychiatric assessment and certification from the psychiatrist. Okay, next question. This is again my favorite question. I was again and again emphasizing when schizophrenia question comes, most probably it comes from the antipsychotic. And in the antipsychotic, most probably it comes from either acute dystonia, tardive dyskinesia, or akathisia. These three. So this already discussed in my previous GMI class. So the answer for this question, what is the question telling? The patient has taken alloperidol for the past 2 years. So it's a long term. It's a long term and represented with the orofacial dyskinesia, coriform and tick-like movements and possible dystonia. What is the probable diagnosis? This is what they have asked. So I have given a beautiful table in your GMI session as well as in your dopamine search. So acute dystonia, it occurs hours to 3 days, but in our question they have given 2 years. So definitely this is not an answer. Okay, and next is akathisia. What is akathisia? Restless movement, restlessness. Okay, that occurs again in 3 to 10 days. So again, akathisia is not answer. Pseudo Parkinsonism, yes, it takes 5 days to weeks, but the features of it is going to be bradykinesia, tremor, rigidity, and masked faces. So again, this is not going to be the answer. Okay, so that you got to know. Next, finally, you have tardive dyskinesia. I've told you, right? Tardive dyskinesia can occur months to years with lip sacking, tongue protrusion, and chorioarthroid movement. So the answer is tardive dyskinesia. Now, the second part of the question is, what is the treatment? So, for acute dystonia, remember guys, the treatment is promethazine. Okay, the treatment of choices, promethazine or benztropine or benztropine. So, in your FMG exam, conducted recently, they have asked about the benztropine. And now in this exam, they have asked about the tardive dyskinesia. So, the answer is tardive dyskinesia. And in tardive dyskinesia, what do? We will stop the anticholinergic and stop the causative drug and switch to venlafaxine. Why we shift to the velbenazine? Velbenazine is a VMAT inhibitor. So it will be like stopping that all this movement right now. And then you can go to the clozapine, which is having a least extrapyramidal symptom in the antipsychotics. So you can shift to clozapine. Now coming to neuroleptic malignant syndrome, it can occur anytime. So it will be life-threatening situation, emergency situation. So that time you need to stop the antipsychotics. Dandrolin and bromocriptine has to be given and ICU care is needed. Okay, again this table I will share as a PDF, but then you need to understand the difference between acute dystonia, tardive dyskinesia, akathisia and oral tremors. This is explained in detail in dopamine search video. Okay, next question. A young man presents with a psychiatry OPD reporting that whenever he sits in an open place, he hears a bird flapping their wing and believes it's a sign from God directing him to move in a specific direction. He follows bird's movement as if they are divine instruction. What is the following? What are the following psychopathologies best describe this experience? So, what is the patient telling? Patient is telling that the normal bird, which is actually a normal perception. So, bird is a normal perception. To that normal perception, so when you take bird, so what is a bird? Bird is a normal perception. So, to that normal perception, you are going to imply some other meaning. Like if the bird is going to travel in one direction, that is a divine instruction for me to travel. So that is delusional. So there is a delusional perception. So the patient will be having a normal perception, but that normal perception, for example, he can identify it as bird, but he thinks that bird is navigating for him. That means there is some delusion. So the answer is delusional perception. So I have already told here the same example I have given you in the dopamine search video. Ordinary perception given delusional meaning is called as a delusional perception. Clear, right? So with this, I think we have completed the recall session. Guys, just remember one thing. This is not going to be the end. If at all you guys haven't performed well in your exam. Okay, if at all you guys haven't performed in your exam, well, don't worry. This is not going to be the end for you guys. There are lots of things there ahead for you. I wish you all the best that every one of you who are seeing this video should get a good score in your NEET PG and should get the required dream choice, okay, required or dream branch you should all take and you should be like successful in it. I pray to the God that at the end of the exam result, all my students, those who have been seeing the dopamine search videos and GMI sessions should get a good score and get the dream branch. Okay. As a senior, as a guide, I wish you all a success. And those who are yet to prepare or those who are thinking to repeat in the next NEET PG 2026. I hope that you guys will look into all the mistakes that you are doing and concentrate on the improvement of your own knowledge and make it a useful one and achieve a success in your exam. So I wish you all the best, and I think that Dopamine team is bringing up a exciting courses ahead. So for example, we are planning for a offline sessions also in the upcoming days, and we are going to maintain this same rapid revision format so that you are going to achieve a success understanding the required concept, and at the end of the day you all get your dream branch, and that's exactly what we want, and that exactly our ambition, our dream also. So with these notes I would like to conclude the today's session, and thank you once again guys for joining with me today. See you all in the next session.